we're here. Innovative benefit strategies. I think it says 10 creative ideas around healthcare was the title of the presentation. So that's where we're going today. And my name is Anthony Fioretti, for those of you who don't know me. Steve Hook and I will be co-presenting. We both get involved with a number of our clients in building, managing, updating benefit strategy full-time. Okay? And while every customer is different, they're in a different place, there's kind of two common themes that are always out there in a benefit strategy. One is managing cost, and the second is maintaining the value for your employees. Right? We're balancing cost and value all the time. So that's not always easy, and we have to be thinking of the next idea all the time. And that's really what this is about. We're going to talk about next ideas. Some of you might already be there, so we'll welcome your contribution to your experiences. Some of you might be far away, and the 10 items, highly unlikely applicable to all of you, but I think there's a good mix based on what we know is possible, dependent on group size, et cetera. So that's what this workshop's about, the next idea. So before we get going on the presentation, I was going to thank our Anthem representatives because they sponsor HNI University benefits events for 2012. They're helping. They helped us get these great little noisemakers. Very high investment as a sponsor. But no, they also contributed this book. It's called The Company That Solved Healthcare. Anyone familiar with this book or read this book? Read the book?
I'm halfway through.
Yeah, I'm in certain chapters.
Okay. So about half are familiar, and Steve actually, he's not directly referenced in here, but he was very integral. He was at Anthem at the time, the Tarinas and Serigraph. This is about Serigraph, which is a kind of a mid-sized manufacturing firm out of West Bend. It's been very innovative and progressive. Steve, during his time at Anthem, helped them deploy Anthem resources to support the process. So you guys all will walk away with one of these if you already read it. Give it to someone who needs to know, what some of the next ideas that are passed to these guys look like. So I want to go, before getting into too much content, I wanted to kind of confirm, kind of the why you chose to spend time here on this special extra day every 4 years that we get, this leap day. I'm not going to go around the room, but a couple people maybe say, what appealed either in the title or in the contents of the invitation? What are you trying to get out of this? Anyone? New ideas. Okay.
Maybe the implementation techniques. Maybe we know some of the ideas in that, but how would we actually go about it?
Okay, did everyone hear that? Implementation techniques, new ways to implement some of these ideas. One other person, anyone chime in on maybe the why or what they hope to get out of this?
Fight rising costs.
Fight rising costs. There we go, right? Let's be out there. Not a simple thing, right? Okay, well, what we're going to start with is just kind of probably some common sense and some setup. I'm going to do that, and then we'll get to the core presentation, hopefully reasonably quickly. So, innovative. What does it mean? Somebody already said it from the beginning. It's something new, a new idea. I think that was the exact quote that I think Gina said, but others said, and so that's what we're working toward. We chose to broaden the view a little bit because, again, this book, a lot of things have been implemented somewhere, but what's innovation to you is based on what your starting point is. So it might be something creative that you haven't deployed yet, but it's not new. It might be original to you, et cetera. So that's kind of innovative, and that's what our charge was, to come up with things that meet that definition. Okay, so what's a benefit? Somebody just define a benefit. Donna.
Well, pretty broad. Part of a total rewards package that goes above and beyond what comes received and paid to provide them resources for receiving care for themselves and their family and protect their future.
That was very good. Very good. I was going a little simpler, but very, very good. A very professional benefits person. But this is the more literal term, and it's simple. I've got a lot up there, but it's a thing that helps, right? What's a benefit? Something that helps, right? So when we're talking about healthcare, back to Donna's kind of deeper explanation, what helps people with their health? What helps people with financing healthcare? What what helps people understand what's going on in their health or their family members? A benefit is supposed to be a positive play, right? And unfortunately, I chose the opposites here just so as we could, cost is an issue, and it's translated to the employee. It could be like a minus. It's not a benefit sometimes, the way that some of our programs have evolved. We don't want it to be these things that are in red, right? Everyone agree? A hindrance, a bunch of hurdles to jump through, that kind of thing. So just clarity on what we don't want and what we want. We want to help. And then strategies, I'm just going to walk into this one. We're going to talk about a number of tactics and strategies that, strategy is a kind of a complete plan, right? So some of these are sub-pieces of a plan. You may have a strategy already, but you don't know how to get at maybe engaging your people as consumers better. So we're going to, one at a time, they're not a strategy, but they're tactics in support of a strategy that we're going to cover. So with all that, my notes say, why all the bells and horns? We have the horns. We don't have the bells. And the horn was going to be one of those like whoopee cushion sounds. Okay, we don't have that one. But we have the horn, which this one, Gina, why don't you blow that horn for us? Because we want you to weigh in. Okay, we want to be respectful, especially Mr. Cook over here, who gets thrown off by things during this presentation sometimes. I'm just kidding. I'll probably get thrown off. I'm already thrown off. But the horns are a positive. I like this. I think we could apply it in our situation. The whoopee cushion noise, I guess we'll just take silence as either whoopee cushion or not sure. If you want to do a hands up, thumbs down or something, I don't think everyone wants to do raspberry noises out of their mouth. So anyway, that's what we were going to do. But feel free, I guess the point is to just weigh in and say, I like that one. Okay, we're gonna go pretty rapid fire through 10, really 11 things. Anyone who's seen Spinal Tap, the guy that, the amplifier, they normally go up to 10, and he says mine goes up to 11 or something like that because it's really loud and metal. But anyway, we have 11 innovative strategies, but don't count. I already did it. But anyway, so we're going to weigh in. Anyone want to test their horns besides Gina, or we'll move on? Come on, there we go. We want. I don't want any sleepers. Okay, so what's the next idea in healthcare? Okay, or why the next idea in healthcare? We're going to talk about why do we need to innovate? What's going on? What do we need to do to make a difference? And we believe there are three main reasons we need to innovate. And one is all about the healthcare system being broken. I feel more comfortable. Donna used to work at a healthcare organization until this week. So, health system is a little bit broken. The financing mechanism, how people get care delivered, and I don't feel as bad because she now works at a service-providing organization that isn't in healthcare. So this is a very busy picture that I don't expect you to understand, but this is one depiction. Somebody, the New Republic in 2009, try to describe what the system is. And the colors represent the various stakeholders, the payers, the employers, the providers. The arrows, you can see they're different colors and some are dotted lines. That's the financing scheme, where the money's coming from. Some's tax, some's our direct payout of our employer plans. It's ridiculously complicated is simply the point here. And how do we expect our people to get value from it and to understand how to manage in a broken system? The one point I want to take away is a recent study by PricewaterhouseCoopers that anything that we talk about when we talk about studies, you don't have a lot of handouts here. We're going to post to our website so you can get them. If you want to support a decision or an action. But this PricewaterhouseCoopers study said that of the $2.2 trillion we spend on healthcare in the United States, $1.2 trillion is waste. That's 55% of everything that we spend is waste. So there's a lot of opportunity, and it's a function of all these arrows going all these different directions. The second reason why we need a next idea has to do with behaviors. There's a lot of them that we need to change based on the way that our systems have evolved and our people have evolved. So this one's pretty straightforward. The food choices people make, how do we get there? I got, for the ladies, I got Brad Pitt, a couch potato, smoking a cigarette. We have those people. How do we change those behaviors? Those are kind of in the my health space. The next level is in the consumption space. So this is really just direct from one client's analysis that we did that says, how do I choose, as other behaviors, how do I choose to access care? And many don't know that in the emergency room for these primary care type services, that's what this exhibit is talking about, you spend almost $400 versus in the office, our plan paid $60. So how do we get people to make the right choice? Is a high enough copay going to do that? What else do you need to do? Let's talk about the harder ones, like how do I know which surgeon or what MRI facility to choose? Again, many of us may be closer, or some of us may be closer than others, but to understand that is really hard to do. And we need to influence the behaviors of choice around care. This one talks about the providers. Providers saying we did everything. Well, that's the fee-for-service medicine world at its core. They're going to try to do everything. Is that really the best use of our healthcare dollars? Let's see what I have next. This is really just, you don't pay too much attention to this except for the top 3%, 5% spend 48% of our dollars. We've all seen that. Well, I believe part of that is, we believe, is a function of how our benefit plans have evolved around the calendar year. When we get done with our deductibles or our out-of-pockets, again, what incentive is there to choose a different provider or a different course? It really doesn't matter anymore. And in the book, Therese and Surgraph have done some things. That's one of the harder things to deal with. But we know that it doesn't stop after, after we get sick. We don't want people to stop thinking about things. We want them to do what's right for them, but we also may have an obligation to our community, our company, et cetera. So that's a hard challenge. So the last why, and then I'm going to turn it over to Steve, is about providing benefit value. Remember in the beginning, it was managing costs was one thing, and balancing benefit value. This is a very simplified look at a slide you've seen in other places, I'm sure. But the green line is health insurance premiums or premium equivalents. Employer or employee, it doesn't matter. The line is about the same. And the gray line is workers' earnings. So over this time, we've tremendously eroded the take-home pay of our workers. So leading to, is our benefits really a benefit anymore? And this other piece, which is about deductibles over that time, same thing. that was premiums. This is now when I go use the plan, I'm getting less and less. Our benefit's a benefit anymore. So those are the three whys that we talk about in terms of why we need to continue to innovate. Again, the broken system. Second one was we have a lot of behaviors that need to change. And the third is we've got to find ways to retain benefit value for our people. So, obvious question, is healthcare reform going to do it all for us? What do you guys think? Any horns for that?
It makes the first one more complicated.
More complicated. Oh, my man, on cue. Watch this. This I got from Mr. Hook in one of his first days after. This is the reform system, okay? And again, it's only to illustrate. We've maybe incentivized some streamlining in some areas, but we've created a lot of other bureaucracy that may get in the way of the simple work we have to do. So, I don't think that healthcare reform is going to do it. I don't think you wait for some Supreme Court decision to decide what you're going to do. We think that you've got to act, and you've got to act progressively. So, what I just said, those three things, do you guys think that's the issue, the problem, or is there more to it? You don't think so, Diane?
Oh no, I think those are the issues in that, and I think the you know, when we talk about consumerism and that, it's difficult to get employees involved in that, and part of it is just, you know, a lot of their day is spent working, and then they need to go home and go on the internet or go on to the various websites to look to see, you know, what they should be doing or where they should be going and that. So we have to make it a lot easier for them to access, I think, some of this information.
Anyone else? Those are the problem, I think? Well, I've seen heads nod. What if I told you that we don't believe that's the problem, that I just wasted 10 minutes of your time talking about things? I bring this up because in rehearsing this with our CEO, he kind of challenged us to look deeper and define that is not the problem, but those are issues that are part of the problem. But the problem is our willingness to innovate and move forward with things that are at the table for us. I'm going to read a passage from the book. This is the last part of John Torina, the CEO of Westman, or of Surgraph. He says, "I'd like to make a class action apology for all CEOs. We allowed the mess on the economic side of healthcare to happen. We did not use the golden rule. He who has the gold rules. We are the payers, and we let loose the beast of hyperinflation in healthcare. We did not trust and empower our people to help. We did not create a marketplace. The best form of price discipline. In the absence of strong leadership from business, we defaulted to government to take the lead on pricing policies and procedures." And then his last statement is, "I've been embarrassed for all of us who should have been in charge." And it was about innovating and taking the forward step. So again, we think innovation, creativity, trying new things is what's going to change the market. And I'm going to go from here to not the opportunity. That's something that we'll end with that, but lead to the specific strategies. These are the 10 items we're going to cover. We're going to do it in rapid-fire fashion. You have in front of you an evaluation form. It's two-sided. Okay? You have the presentation, you have the evaluation form. On the back side, it doesn't say front and back on it. There's these 10 things framed. Okay? And I guess since we're going to go kind of quickly, we're going to pause at the end of each. That's when you can blow your horn if you'd like to. Say, I kind of like that one. But at a minimum, keep score here, because we're going to then go back and do a deeper dive on the things you want to talk about after Steve maybe gives us 45 minutes of kind of content, rapid fire style. Okay? So keep score, and we're going to go from here.
a lot of you know that I've spent most of my career on the carrier side. And one of the jokes we used to talk about, because I never really worked in the home office very much. I mean, I can't say I never did, but most of my career was out in the field offices. And so we used to always joke about, when people would come from the home office, they'd always show up and say, I'm from the home office, I'm here to help. Well, we always knew that was a big joke because they just, made things difficult and fired people and changed organizations. And now, I've kind of switched talking about that because we've got, as Anthony showed in that one slide, we've got the government coming out telling us, I'm from the government and I'm here to help, and we're going to fix all this stuff. And that's why we have healthcare reform. But how do you all feel about today? I mean, I look out here and I feel like I'm back in school. We got sort of a crowded room, a little bit warm in here. Got two old guys up in the front doing all the talking. Well, just in case you're thinking that there's going to be a test, let me just tell you the key message to take away. So if you want the one key thing of all what we're talking about today, is that change is coming. Anthony alluded to some of the dollars and cents, but the reality is that 20% of GDP almost is being spent in healthcare in this country. We just simply can't afford what we've built. We've built a very expensive, complicated, high-quality healthcare delivery system over the last 40-some years, largely driven to where we are by the way it gets paid. It's pretty simple. If you put the carrot out there, people sort of get attracted to the carrot. That's why most people live around water, because they need the water, so they live around big bodies of water. Well, the government's also now involved with making change and driving change. And so with as much money as being spent in healthcare delivery, just about everybody in this country is either going to be affected by the change that's coming or you're paying for it. So if you're either paying for healthcare or receiving healthcare, change is coming whether you do anything or not. And that's what we're going to talk quite a bit about. I
left one thing out. We got 3 bundles of top. First one is about primary care. Second one's going to get into incentive groupings. That's how your things are grouped there. And the third is what we're calling smart quality purchasing, smart purchasing. There's overlap amongst them all, but primary care is a huge lead.
So we're going to spend some time talking about what's changing on the delivery side. Clearly things need to be changing. And so we put together some information to spend some time talking about some of the things that are moving forward in the literature, some of the things that are moving forward from a government standpoint, and things that are also taking place in the local market that you can take action on. But right now, there's about 27 different pilot projects going on around the country. They're being financed by the government as part of healthcare reforms, money that's available to drive a change in how the delivery system is working. And there's 2 primary components to that, how it actually delivers care and how they finance care. So we're going to spend some time talking about some of those things. And we bucketed into 3 different areas for you to get some information about. Provider-led changes, insurer-led changes, and then what the employers are actually doing. Sometimes this works and sometimes it doesn't. I got it. That works. So, you've probably heard a lot about this concept, the patient-centered medical home. A lot of the change in the delivery system is really focused in this particular area. And depending on, there's new acronyms coming out. The emphasis on these pilot projects is all around this concept. Central to this is around the primary care physician, or in some cases a personal physician. It doesn't have to be a primary care. But central to the changes that are coming forward is about changing our consumption patterns and the changes within the delivery system in terms of how you access it. These are all sort of standard ideas that are in virtually all of these pilot projects that are taking place. What's driving it, the catalyst of making this change, is this last one, the payment reform. The federal government being one of the largest payers, about half the health care delivered in this country is paid for in an employer-sponsored market. And the other big payer is the government, either federal or state or combinations between Medicare and Medicaid populations. They're threatening to change how they pay for what they're getting. Employers are starting to threaten to change how they're paying for what they're getting. And that's what's making the delivery system get organized in a different way. What we'd like to do is just sort of level set. We've got this short little video that talks about this concept. So for those of you who already know, this will be a little redundant. For those of you, this might be new. We thought this sort of frames the conversation for the rest of the day. You have to scroll down and choose language.
What language would you guys like?
Let's try English today.
Okay.
Hello, welcome to Emmy. I'm here to tell you about a better approach to healthcare. So let's get started. Okay, everyone's health needs are different, but whether you see your doctor once a year or a lot more often, it can be a hassle. First, it's often hard to get an appointment. You rush to get there, but you may end up waiting if they're running late. And your doctor's rush too. So even though she'd like to spend more time with you, she only has a few minutes to find out what's wrong. The fact is, you may end up feeling like just a number or just the next person in a long line. So your doctor only hears about your sore throat or swollen knee, that pain in your back, or your daughter's cough, and there's no time for you and your doctor to really talk. It's even worse if you have a problem in the middle of the night and you're not sure if it's serious. Do you wait and try to get an appointment? Or do you go to the ER where the doctor doesn't know you and wants to run all kinds of tests? Will your insurance cover all those? It's a lot to deal with. And it's even more complicated if you need to see specialists, like a cardiologist, an allergist, or a dietitian. That's a lot of different healthcare providers giving you tests, prescriptions, and treatments. And no one provider knows what the others are doing. When you think about it, they're each just looking at a piece of you, so no one sees the whole picture. Shouldn't this be a lot easier and less confusing? Well, yeah, that's why there's a new approach to healthcare that puts all the pieces together. It's called the patient-centered medical home, and it's a way to give you better, more personal care. Now, even though it's called medical home, it's not a place. It's actually much bigger than that. It's a whole team of people who know you and work together to give you the best care. It's led by your personal health care provider who gets to know you well and works with people like nurses and pharmacists to make sure everyone's on the same page when it comes to your care. There are also people on the team to help you with things like medication costs or insurance questions. Basically, your team is made up of whoever you need, so it changes as your health needs change. For example, if you need a specialist, your team can help you find someone who's right for you. And your personal provider will keep up on everything and help make sure the whole team is in the loop about your treatment. In fact, many medical homes also use things like electronic health records to help coordinate your care. That way, you don't have to keep going over the same information with each healthcare provider. Look, your time is valuable, and your team knows you've got a lot going on. So with medical home, it's easier to get care when you need it. If you've got a problem at night or on the weekend, they want you to call. And you may be able to get the help or information you need without even going into the office. Or if you need to come in, the schedule during the week is actually a lot more flexible. So you can often get a same-day appointment, or even a longer appointment if you need it. But patient-centered care isn't just about getting help when you or someone in your family gets sick. It's about preventing problems so you stay healthy. They'll make sure you get things like a yearly checkup or any shots, and your care is tailored or custom-made based on your health and family history. So if you need any kind of test, they'll contact you to explain the results and to schedule any follow-up care. Because once you have the whole picture, you and your provider can work together to make decisions about your health. It's a partnership, so speak up. After all, they want you to ask questions, and they want to hear about anything you'd like to change or improve. Do you need to get more sleep, lower your cholesterol, or lower your stress level? They'll help you set goals that make sense for you. Then it's up to you to make those changes and to let them know how it's going. And when it comes to things like asthma, diabetes, or high blood pressure, they know this can be overwhelming. So your team will make sure you get the tools you need. They'll also take time to explain everything, make sure you have the support and resources you need, and listen to your concerns. Because caring for the emotional side is just as important as the physical side. After all, you're not just a name on a chart, you're a whole person. And with the patient-centered medical home, your team provides health care that fits your life. So you feel taken care of and, well, at home.
So does that sound like a good place to go? Would you like to be in that cartoon, living that?
Sounds a little bit like your HMO.
Doesn't it?
Yeah.
Any other?
Does it sound like
Yeah.
what you expect to happen anyway?
Yes, and now would be nice.
No. Well, you've been conditioned to not providers talking about how they're going to deliver care, right? I don't know how we activate that as an employer. But let's go to kind of the next.
Well, I think most of us would agree that if we could get there, a lot of the other things we talked about earlier would kind of go away or be changed significantly. And it might be a great goal, but I think that we all experience it completely different today, and we know that it's going to take quite a bit of time to make all that stuff happen. But, as I said earlier, the catalyst of making a lot of this happen on the provider side is actually, we're already seeing people align themselves. This isn't really a new concept, obviously. But the provider systems around this state and other parts of the country, is a little bit different. But in this state, they have been for a number of years very organized around building what we commonly talk about as vertically integrated delivery systems. Aurora, being the biggest one in our backyard, has been very busy in the last 15 years buying up all sorts of capacity. It's hard to find an independent, freestanding general doctor anymore. They pretty much don't exist. All those practices have been bought up by somebody in the marketplace, and Aurora has been part of that. They've also built, virtually all of the components. They have their own spin on this, and they're actively pursuing, aligning themselves to put themselves in a position to take advantage of the changes that are coming from a reimbursement model. And they want to make sure that they're kind of leading the charge there. These are the three core tenets to what they believe needs to be in their system that they're bringing forward. And in fact, they have already brought forward this and are now offering it as of just a short while ago, like a few weeks ago, they got permission to move forward.
I got it. This is the accountable care organization. If you're keeping score, we're going to skip the patient-centered medical home and just go, not thumbs down on it, but not really actionable for us. So this is a way to activate it. Keeping score, interest in this, what he's done with not the Aurora product, but the concept. And again, you're going to see various products. We chose purposefully to show you what's really available today along these themes. And so Aurora, as Steve was saying, has a product to deliver an accountable care organization model today.
And kind of different from the public school setting of talking about theory, we really are focused on talking about what's real, what you can do when you walk out of this building today. This is what Aurora's system looks like today. They've pretty much gone around and bought up all the stuff we're built in these blue spots. So when you think about what they can deliver, they own it all already for the most part. They're gluing it all together on the bottom there with the electronic medical record. And they've already implemented that, and as well as a lot of others around town have done so. But with their accountable care organization, or their ACO, they've added a couple more components to make all this stuff work. Did you do that for me?
Yes, I'm doing it. I see you going like this, so I'll do it.
The first one on the left, it's hard to read. It says on-site nurse navigator. When they're in the marketplace offering to employers an exclusive network that could replace your existing network if you're willing to give all of your business to Aurora. It would look like a current PPO, in-network's Aurora, out-of-network is whoever. They've added to their product, if you will, this on-site nurse navigator. So if you have a location with 100 or more employees, they'll put a full-time nurse on your site. The nurse's primary goals are twofold. One is to promote and educate people on wellness. The second is to make sure they're compliant and understand how to use the system. So it's a very valuable resource, I believe, in helping with a patient population navigate their way through and also have a real strong connection to compliance and adherence to medical treatment to drive outcomes. Because at the core of this is changing outcomes, health outcomes, changing behaviors, changing the results, changing the financial picture. On the other side, they have taken on the responsibility that most all of you, if you're self-funded or if you're fully insured, someone is doing this in your population now. They're managing large cases. They're managing the complex cases. So they have a care management component that is responsible for coordinating when you have multiple disciplines. And some of the more sick people, the more chronic, the ones that are sort of driving you crazy in terms of your cost, it's not uncommon those folks are seeing 7, 8, 10, 12, 15 different providers simultaneously to treat the same condition. That requires a lot of coordination. And while the IMI that we saw made it sound like it was simple. We know when you've got 12 different quarterbacks in the huddle and you're the patient in the middle of that huddle, getting them all to agree on what they're going to do could be a challenge. They've been doing this for a while. This isn't brand new to them. They've organized, they've obviously invested a lot in making this happen. And they've got outcomes to prove that it's working in terms of driving improved health outcomes. And a couple of them on the right-hand side is talking about their cardiac patients and on the compliance of having low cholesterol. And they're comparing themselves to the national average where they're running at 76% and the national average is at 46, and even the best practice statistics, they're 6 points above that. The one below that's a little hard to read is about A1C for diabetics and getting people to have the right A1C score from a blood test. And the same kind of data is there that when they control the population and manage all the components, they're delivering these kind of outstanding results in those patient populations. So what does it look like to an employer today? Well, as I mentioned, they just got permission a few weeks ago to be able to offer a financial guarantee. You know, this space is regulated by lots of places, and because there's this cutting edge, a lot of people get to vote on this. But one of the things they needed to clear was with the Department of Insurance, whether or not they could offer something that sort of looked like insurance. And so what they've been able to do and got buy-in is they review a client's data, and they'll give you a proposal, if it makes sense, for whatever part of your population that they were willing to go on risk for. But they'll give you a claim target, and then they guarantee in years 2 and 3 that it's not going to exceed those numbers. So when you look at it from a 3-year window of time, they're pretty much putting themselves on the hook for delivering a fairly tight cost number in return for your business, if you're willing to structure a benefit plan that way.
So this is the horn time, but before you don't vote on it because it's Aurora or not.
Well, don't go there yet.
All right. I just want to talk about the we.
Don't go there yet.
All right.
It's in another slide.
Oh, all right.
This is cutting edge stuff.
Are we going to go to the next topic?
I thought you were going to vote on this.
Yeah. No. Okay. That's what we were going to do. Anyway, I guess this completes the picture. If you could have that patient-centered medical home concept that we all like, and 15% cost reduction, and year 2 and year 3 guaranteed.
Is that a claims guarantee or a premium?
This they're in the process of they've got their self-funded product approved, so it's a claims guarantee. Okay, which is quite powerful. Okay. At the same time, there's all these insurance companies that are wanting to represent this product from an insurance premium standpoint, which you would expect to have a rate guarantee if you're fully insured. That hasn't been completed yet, but this is what they're talking about. The article that I can't tell you about, the rest of the world is trying to do things that are similar to this. But, a positive form to consider for innovation, or not for me. Score it on your page, blow a horn if you like it at all. Wow.
This is a half-hearted. I'm a little
Half-hearted
of Aurora. Excuse my bias.
Right. Now, I told you to strip Aurora out because this could be up in Green Bay. It could be,
Chickens have that
Bella
reaction to
Theta,
boxes.
and
Yeah.
the Bella products like this. So kind of ignore Aurora. But I think the point is, if we like the patient-centered medical home concept, they are capable of delivering it. And if they put their money where their mouth is, it's, Gina, we're not trying to sell you on anything.
I
We're
know.
trying to show
Okay.
you where the opportunities are.
But at this point, it is only offered to companies with more than 100 insured.
No.
The only way you can get their product is to be self-funded.
Okay, that's right.
Right today.
Today.
They've been saying
And
or
it doesn't
one.
matter size.
No, not really. I mean,
You
they're
get the
looking for
nurse
larger
navigator.
populations.
You get the nurse on the left
Right.
side
Yeah.
if you have 100 or more
On-site.
people at
Okay.
your place. Okay. But go ahead.
Which means if you have employees all across the
I
country
see this one.
where Aurora does not exist.
See, that's one of the barriers that make it less actionable for some. But if I'm concentrated here, or let's put myself in a different place, I'm concentrated on the south side. okay, where Aurora kind of is a dominant provider anyway, it's going to make sense to contemplate it. And we have a number of clients in that space that want to see it. They're not sure they want to put all their eggs in that basket, but they believe in promoting primary care to their people. They believe in all those concepts. And again, Aurora, again, our side of the equation, the employers, put the test out there. If they back out when they deliver all their proposals, that is not a real thing. But how do we know until we push that button? Is kind of what we're trying to get at, is take advantage of what's there.
Are there other organizations that are close behind them?
Yeah.
Yeah.
We'll talk about
I can't
some of
tell
those.
you about it.
Well, what do you do if you have employees who live in other parts of the country and can't access?
Well,
is there like a wrap that
Well,
would
yeah,
work?
you have to find a solution and this kind of a solution is really only going to appeal to those sorts of employers that are spending large dollar sums in the Aurora footprint today, because it doesn't solve any of the other stuff that we would do. We would solve those with a different network and have a different solution. So for those employers that have been moving toward consolidation, similar benefit offering all across their populations for years to get them all the same, this is kind of going backwards from that strategy. But depending on what you're spending in Aurora, this might be worth doing for your Aurora footprint.
Let's move on. That's accountable care organization. Those are provider-led initiatives. Now,
Here's another version. We're going to talk a little bit about WPS and what they're doing at Patient Choice. And then we're going to talk a little bit about a brand new product that United has put out that is also in this space. It's really focused on the primary care model. If you're not familiar with Patient Choice, they offer kind of the opposite of what we just talked about. They have everybody but Aurora, and you have choices. You can have everybody, or you can have a narrower network. So you can. What I've identified here is the Wheaton Franciscan system. You know, they have what the Wheaton Zone plus some friends at the bottom. ProHealth has a similar offering with some friends at the bottom with some of the same friends. And then Columbia, St. Mary's, and Freighter together with some other friends at the bottom make up their network. So the way this looks, if you've not seen it, your employees choose. And each one of them has a different price point. So people are selecting a narrow network with a multiple choice. This concept came from Minnesota, where it's been going on for 20 years. And it's very effective, and it's delivered, you know, controlled costs and beating inflation. But how this would look to your employees, this is an example of one of our customers that has this. This is showing a renewal. So what we've circled at the bottom is the plans are essentially the same for all of the options. They're offering the statewide network that has everybody, and it's got a price point of $750. Then you've got this Wheaton's Franciscan, and it has a price point of $593, which is about 20% reduction. And then you've got a 13% reduction if you go to either the ProHealth or the Columbia St. Mary's solution. On this particular example, those prices turned out to be exactly the same. So this is an enrolled choice, but when someone picks their system, they're in it for a year. So another version of how this is being rolled out. You want to flip me? UHC is reintroducing an old concept, the gatekeepers. A lot of you are probably familiar with having gate-kept products before. So what they've done just recently, and they're effective, they just started quoting this stuff a couple of weeks ago, and it's effective for April 1st. This is, I'm going to show you an example. The way this works, they're using the exact same network that they always had, the broad, deeply discounted network. The same plan design, so they're no different. So no matter what you have, consumer-directed, HSA, HRA, it doesn't really matter. Whatever plan design you have, or if you're with them have, that doesn't change. But if you're willing to go to this Navigate product, on a fully insured basis, you get one version of this top line. And the only thing that your employees have to support is they have to go get to a primary care doctor, select a primary care doctor, and have that doctor make referrals. They can refer into anybody's system. So if you're going to an Aurora primary care doctor, I suspect they're going to likely channel you to an Aurora specialist or an Aurora facility if you need some additional care, but the product doesn't make you do that. They can refer you to anybody. What's different about this version of primary care or gatekeepers from what your experience might have been if you had it before is the advancement of technology on the referrals. For those of you, I hope you'll break out in a rash remembering what this was like, but that was oftentimes the difficult problem with a referral process before, was the timeliness of getting the referral so that you actually could go efficiently to the next step in your treatment. and have it work. They've done this all electronically, so all of their doctors have to do this electronically. It happens almost instantaneously. There isn't really someone on the other side of the curtain at Aurora over to UHC saying yes or no. As long as it happens and there's going in network, it's approved. So that's the only exception you have to make. Now you get somewhere between a 7 to 9% premium reduction on your benefit plan.
This is a client of ours that renewed at a +6, and they just overlaid this product. No changes in benefit design. It's a -3. So we're looking at a 9-point swing. This is the same network of providers. Okay, it's the comprehensive United Healthcare network. You just have to drive through primary care first. So what you'll see as a recurring theme is every organization that's promoting something along these lines is talking in the 8 to 15% stripping of waste by driving through primary care. That medical home concept is just delivered in a number of different ways. And again, that's that product, that type of product. Okay. Gina, any noise on a 7%, 9% reduction without changing your benefit design? Skeptics on primary care back there still? Or are you blowing the horn back there? Anyone in this row? Oh, right here.
We got a question back here, Anthony. Tim wants to know how's it really going to save any money? He knows how it's going to save premium, but what's driving the savings? Well,
I want to hear Lori weigh in on this one. You like it? All right, good.
Well, the answer to Tim's question, they have a pay-for-performance system in the background. It already exists. They believe, their pricing actuaries have said, if we go back to a gate-kept process and eliminate the unnecessary access to the inappropriate care and channel patients, that we will find a utilization savings of somewhere between 7 and 9%. They haven't changed how they're paying for the unit cost. They haven't really changed their medical management model. All they've done is overlay this one component, and that's what their actuaries thinks it's worth. Now, the other thing I was going to bring up, when you look at the WPS product, back to your question, just yesterday in the paper was an announcement that those organizations that are non-Aurora are building an ACO to compete with Aurora. So that WPS product is going to take on a new flavor as soon as they figure out how to make that all work, where they're banding together. Under the legislation that's out there, the requirement is that any organization that meets the credentialing criteria needs to be able to accept 5,000 patients, and they need to be able to service them. So it's, organizations sort of have to look at this and figure out, can we build enough scale and provide all of those referrals inside, a tightly wound system to be able to make this work. If they can do it, then the carrot for them is they'll actually be in a risk arrangement. If they can drive better results, they'll get to keep some of the margin. So the waste that we're trying to get at with these changes right now is going to create free money. And the government's saying, we'll share some of that free money with those who can really figure out how to make this work.
And that's on the Medicare population, a Medicare-approved ACO. Now, again, if you go into the literature, there's a lot of people kind of faking the ACO. Okay, I mean, it looks like an ACO.
Just like in the HMO
when they get approved, they have at least met some criteria to say they're operating like that. That's what Medicare will do. That's what the NCQA, the quality assurance organization that accredited networks in the past, and
they're still out there.
So those things, again, there's a lot of things that might look like an ACO or could be called an ACO, but it's not a done deal until they make Medicare.
Sometimes it takes me a little while to grasp the concept, and I am a finance person.
Okay.
But none of your hospitals go away. None of your doctors go away. None of your nurses go away. And you're saying I'm going to save costs.
Right.
It doesn't.
Well, and this is, I mean, I would, in the insured models, take United, sponsored by Anthem, it doesn't matter. We're going to talk about everybody. I don't trust them, is what you're saying. How are they really going to make that happen? They can reduce my rates.
That's why you hired him, right?
They can reduce my rates by 9% for 1 year, but are they really going to control it?
Well, and
that's the question.
I don't see any difference you're still going to, I mean, there's still fixed costs. Healthcare is a fixed cost.
Well, again, I think the underlying trust factor is, are they really operating in that patient-centered medical home model that is truly coordinating care and eliminating waste along the way? That, again, I'll go back to this is PricewaterhouseCoopers saying 1.2 trillion of 2.2 trillion is waste. And I had a conversation with an attorney over lunch, Steve, you were with me yesterday, who's working with some of these insurers and these doctors, and they're all worried that their pay is getting cut. And it's the specialists, less referrals to specialists. We'll get through a couple of those concepts. They all blend together, these things. The next segment is employer-led initiatives, where you can maybe trust yourself better than maybe the insurer, or the first one was the providers. Good questions, good skepticism, Tim.
Well, so far all I've seen is you're squeezing the balloon. So I can reduce my costs, but somebody else is going to pay because, you know, the costs are still there.
Well, I think let's go into.
And I think you're right on, spot on. If behaviors don't change, whether we're talking about the behaviors of your employees or the behaviors of the provider system, if they don't change, you're going to end up right in the same spot.
Right. But let's go through these, because these kind of unpeel a little bit. The old balloon, I mean, the current balloon, or part of it is squeezing, you know, from one payer to another, and the same care is being delivered. This is really altering the care and the behaviors of the providers are supposed to. And so let's go through.
Another question before I go?
Well, the big thing, though, is the question of trust. And you look back at the old HMO model, and you know, I'm sure everyone here has horror stories about their employees and their care, and what can happen when you have someone else managing, and someone who, you know, do they really have the best interest of that patient? And are we willing to gamble with that? And my company is a entrepreneurship, a caregiving kind of, and this is going to be a hard thing to sell to Peter and Ola. Really hard.
Yeah, they're pretty skeptical.
Yeah.
Well, again, this,
So,
anyhow. You know, what we're trying to do is bring out some of these true emerging things. What is right for everybody is kind of in the vetting process. But again, I would, if I could count on them to do it right permanently, and I'm fully insured, these two things we just talked about apply to the small group, fully insured market. I'd take the 9%, right? That's kind of an easy strategy if I already have the same network, like you said, Tim, but it's maybe not long term. So let's go to some of the employer-led initiatives.
These are things that sort of moving away from the delivery system for a little bit and talking about what employers can do. And we're going to talk a little bit about on-site and near-site care, concierge medicines, and then coordinated advocacy. Now, for some of you, you may be familiar with the QuadMed story, but QuadMed, if you're not, built their own solution. As a large employer about 20 years ago, they said, I'm pretty skeptical, I'm tired of this, we're getting off this train, and we're going to do it ourselves. So they went out and built their own healthcare delivery system. They built primary care, they put it on-site, they put wellness in it, and they moved forward with making all their employees go into that channel. They went then into the marketplace and contracted for things they didn't want to own. They didn't want to do the bricks and mortars of hospitals and hospital beds and surgeons. So they built the network. What they've been able to do over time, this clicker, you have to just stay there.
Yeah.
See my clicker.
Same premises. This is QuadMed slides. I mean, that's what we're trying to do, is bring you what they are talking about. Same premises.
Over about a 20-year window of time, they started off like everybody else, but they quickly got some savings, and the savings has accumulated, and as costs have continued to go up, they're, in the last 10 years or so, they're somewhere between 20 and 30% below industry averages in their cost structure. Go ahead. This is what it looks like in terms of what they built. On the right-hand side, they have these locations where they have their own employees, where they built their bricks and mortar and delivered their care. Then they started doing it for some other large employers that wanted on-site care, so they were rented out, and they built these for these other organizations to also put on-site for them. And then they started offering it in the marketplace to employers that wanted to offer that solution based on their capacity that they had, and we've got somebody in the room that's had some experience with it. And I think the quality of care in this model was actually one of its strongest selling features because they really changed the way the patient interacted with the physician, and that we believe had a lot of significant impact on how the patients actually changed their behaviors and became healthier over time. This is an opposite example. So if you're not willing to sort of make that investment in the bricks and mortar, well, you can do it small. So that was the first was sort of on the big end. This is on the other end. This company hired a nurse, and they hired this nurse primarily to focus on 3 different components. The wellness preventive care benefits of their employee population. This is generally a low-paid group, not all that well educated. They focused on ER utilization, and they focused on mental health and EAP types of issues with the populations. What you're seeing in this chart is the green lines at the bottom is the locations that had access to the nurse. It's a snapshot in time after this has been in place for a while. And then the red lines are those locations that don't. And so what we're seeing, which is exactly what they hope to have, is that the utilization for the wellness services are actually up in those locations where it's supported by a nurse clinician. In the locations from a cost standpoint or utilization standpoint for ER visits, they're significantly better in that population. And the same thing's true with their mental health results. On the right-hand side, you can see what the average cost for those that have the nurse and the average cost for those locations that don't. Pretty significant results. So having one clinician on site can make a huge difference in some populations.
This is a client of ours, Goodwill of North Central Wisconsin. And they have other things working around this that fit their culture, but these on-site resources, not delivering a lot of care, but resources, helping coordinate, educate. This was the slide that we used to invest in more traveling nurses. They have 23 locations in North Central Wisconsin, so they need to now cover the rest of their population. This was the pilot. This was the management meeting that said after a year, how did it play out? So, so let's go to the next one, Steve. Oh, wait. On-site and near-site care. Steve. All right. On-site and near-site. And near-site, let's not ignore near-site, because these folks in front of Velvac, they were one of the people that used the Sussex facility, QuadMed, any QuadMed facility.
Yeah, we had employees that used outlying quads, but we're 10 minutes from Quad in West Dallas, and we use them still for Ahmed as well. But it was fabulous care.
On the near-site care and the effectiveness, and
it's great.
You know, a smaller employer accessing it was a positive. So,
well, I'll add, I worked for a facility that had a doctor on site, and I didn't really have to go to the doctor outside of that for 10 years. I mean, if I needed something specific, she would give me an appointment with a specialist. I didn't have to go see my regular doctor. I mean, there's a huge benefit to it.
Yeah. And again, you trust yourself to choose that engine that's going to do what you want it to do. And again, this is employer-led stuff. So let's go to the next one.
Okay, so
can I just make a comment though? But so much of this employer-led stuff, if you're a smaller employer, if you aren't self-insured, you could arrange all this, and you're not going to get the benefit. The insurance company gets the benefit because we're still part of a pool. And we could be doing rates, but if our group isn't, our rates aren't going to get any better. And that's where all these solutions are wonderful if you're self-insured or larger. I hope you're going to address something that helps sort of software.
Well, just to make sure you picked up on, the insurer let the two things, Navigate and the WPS product, those are available to the small group market. And again, whether they're giving consistently that return for that, you know, the one's been in the market for 3 years, 5 years, and no one's picked up on it. No one has acted. The John Torina's thing. No one's buying it. Nobody's in it. Brokers don't really want to promote it. Oh, it's got narrow networks. It's kind of easy in my mind. I got all the choices. My employee gets to pick the one they want. I don't even have to just pick Aurora myself. I just don't have Aurora. So if I'm not ready to take that action that does any marketplace differentiation, that's not going to work. But those two products play to your everyday. And again, the trust on whether it's going to stay there is a different question. But take it if you can take it, and look for that second, third year guarantee. And again, the Auroras and these other accountable care models, they're going to put caps on it. They're going to find ways. They're going to have to because they're going to be on risk on Medicare. So it is changing slowly, and the more we move, the more we create the snowball effect. And there are things for you. So go ahead, Steve. Yeah.
With that UHC network for products to navigate, I mean, do you have to have a minimum number of participants in each of the offerings?
It's a single offering.
It's a single offering, typically. Now, if
I mean, if you had...
there was three things on the slide that
There's just three iterations of how they can be written.
okay.
But there's really one core.
I sort of skipped over the last two because they're really only available for self-funded employers. They're just variations of the first one.
All right.
And so, concierge medicine. You may be aware of the name. You may have, it's been around for quite some time. It's even got its own TV show now if you like Hank Med. But one of the things that Chirinas did was sort of venture into this space as well and pioneer. And it's developed into, typically the concierge medicine idea has been delivered to the affluent, people who can afford to hire their own doctor, kind of put them on a retainer. That's the model that sort of has been brought forward for in lots of places around the country. Not a very usable solution, unless you're talking about your key executives. You might want to give them a special perk and give them something like that. But there's also now been moved forward, the same concept, but put it into place on a near-site or on-site clinic. The ideal setting is to do it in an on-site clinic, where instead of going out and dealing with having someone be assigned to a physician on a personal basis, this is sort of taking a different twist. And the company offers for your employee population to choose, anybody can choose this product, that when they do that, they're going to pick, they're all picking the same doctor. And the doctor's going to be, in an office someplace on site delivering care like Tim was talking about in his past experience. That person is now responsible for all of your health care, and they're going to help coordinate all of the health care through the rest of the system if you need to go outside the system. So that's sort of what is being moved forward. It doesn't have to be delivered completely on site because this is also for the dependents of an employer population. And a lot of employers don't want to have the dependents traipsing through their plant to receive medical care, having kids in a waiting room and all the rest. So oftentimes what's done simultaneously, even though they might have an on-site clinic, somewhere in the close proximity in the community, they'll also have an office that will treat anybody who wants to go there, whether the dependents or the employees, doesn't matter. The patient gets to choose. So the doctor will rotate back and forth between the on-site and the near-site clinic to support the needs of an employer. Depending on how many employees you have that sort of pick this model really focuses on changing the dynamic from the physician's perspective. Instead of having 3,000 or so patients, they're going to have probably about 500 patients. And then they're full. So if you have more than 500 members that were receiving care in this model, you'll have more than one doctor. And you might have more than one doctor available depending on where your employees are. But the point is that you're going to have a very small number of physicians treating all of your employees for primary care. They're available 24/7. And I'll get into some of the other components. But what it does is it changes sort of that patient. Again, it's one of those things that's really focusing on changing how care is delivered around a primary care model. These are some of the main components of how they go about doing it. Very, very strong focus on wellness in this model. In fact, in this model, everybody who enrolls in it, the first thing they do is they take a pretty complex physical. You come in, you meet the doctor, you spend quite a bit of time. He gets to understand, or she gets to understand who you are as a patient. And right from the beginning, they understand and build a treatment plan, and they know what needs to happen. So if you present with issues or you're on maintenance medications, you already got some sort of disease or a chronic situation, they will engage right from day one. They don't wait until you have the next episode of care. They're going to be on it right from the beginning, get to know who you are, and figure out how to help you manage that condition. This is, I mean, kind of how it works for the three different populations, the patient, the physician, and the employer. Everybody wins. This is a triple win for the groups that have implemented this. The patient satisfaction is sort of right through the roof. But the patient gets a much higher quality of health care, a much more personal level of health care, and you have a physician who is really responsible for driving the improvements in utilization. So he has, think about it, the doctor has skin in the game here to make you healthy. You know, if you're one of those people that keep forgetting to take your medication and it causes bad outcomes, that's more rework for the doctor. He has a vested interest in making sure he deals with that issue. It changes the dynamic for the physician. I don't know if you guys realize this or not, but the average compensation for a primary care physician is not that great. In fact, a lot of them are making less than $100,000 a year after paying all their bills. So what this does is changes what they really got into medicine to do. And so by changing the reimbursement mechanism and making them more of a partner in the patient's health, it gives them more access, more time to access their patients and develop treatment plans and actually make a difference instead of just, you know, being part of an assembly line and getting 40 people out every day to keep sort of a roar off their back. This is what it does from a financial standpoint. This is how the model is built. You substitute what you're currently spending for primary care into a capitated model where you're paying this doctor a flat fee for the patient population that enrolls with them. From the member standpoint, the incentive is there's no barrier to access, no more co-pays for primary care, no co-pays for anything that is delivered in that medical setting. So they win. What it's supposed to do is drive down specialty care. You know, the model is intended to drive down the access to utilization of specialty care, not only from a utilization standpoint, but the actual cost. Because one of the things that this model does is the doctor, before you get referred out to the knee surgeon, he's going to review, he has access to tools, he's going to review what the choices are within the network that you've chosen as an employer. And he's going to look at both the quality and the cost results for the knee surgeons. And he's going to steer you toward the one he thinks is going to give you the best outcome and that he's going to build a relationship with. And he's likely to go with you when you go meet the doctor to talk about why you need to be seeing him about your knee. So he's very much a partner in all that. That's what's going to drive that utilization down. Emergency room, because he's available 24/7, you're not going to have unnecessary needs to go to the emergency room. You get sick, unless you're bleeding or you passed out, you pretty much pick up the phone and call him any time of the day or night. If he thinks, based on your presenting problems, that you need to go to the emergency room, he's going to call ahead, and he may or may not even have you go into the emergency room. He just may have you be admitted right to some part of the department to have some tests done or something to get the care to figure out what to do next. So that will dramatically limit the utilization expense. And then the inpatient hospitalization, not only it will reduce the number of times people are going in to get services, it will also reduce the number of days. And as you know, the longer you're in the hospital, the more expensive it gets. Because he's going to be there to help when you get discharged, to implement the discharge plan. And so people can actually leave the hospital sooner with this kind of a model because you're being discharged to someone kind of almost in your family that's a physician. So
we're at, I just want to, there's some looks. Do you understand the difference between this and maybe the on-site care model? You guys have questions about that? You got it pretty clear?
This is very expensive, though.
It is very expensive, but...
We looked into it. It's very expensive.
Well, go back to this. We're going to take this map that's here, these savings. Are you self-insured?
No.
You're fully insured. And again, this, to your question, we got to have the market change on this one. But I mean, there are ways to build it in a fully insured model. We've been working on it. We haven't found the magic mix yet. It really kind of depends on where you're at. If you're in a
self-insured, I mean, that's not the problem, but it's expensive.
Well, it's expensive, but how much do you spend on primary care right now? Do you know?
But the thing is, it's not like you can drop your health insurance when you have this.
Oh, no.
You know, so you're paying this and you're still going to have it at night or not.
So if you are self-insured, we looked at it as well.
Yeah.
And that's, so you have to believe in the savings. And this is where I bring up that issue of where are the costs going out of the system in the earlier models. Because here you're driving out utilization, which means that in order to reduce the cost of the entire system, you're going to reduce infrastructure. Because you know, the emergency room care, the inpatient hospitalization, that all means you need less of them. That's how the whole system costs go out. This model we really like. We got to get our heads around, but being self-insured, you actually do see the savings if they're real. So you got to.
This will help with the primary care stuff, but then you get someone who has cancer. This isn't going to help a lot.
Well, if you don't believe that
then that's where
care can be managed better.
Right.
And again, I think that's a very large topic. And again, I think Tim, your observations here on where the costs go, these actually go away.
Yeah.
That's what all of these models believe or purport to say what's going to happen. It's who do you trust, right? And if you hired it yourself and you can see the outcomes, you can trust it better. Yes, sir.
And aren't there always winners and losers if they're managing and trying to?
Well, you're fully insured, right?
Yeah.
Have you ever had a year where your loss ratio was more than 100%?
Yes.
Isn't there winners and losers in that system?
Mm-hmm. But I'm talking, and this too, if they're going to be, even the other model you were saying with referrals, you're going to refer to the most efficient, that means someone's going to lose the business and they won't be able to stay in business.
Well, you hit the nail right on the head. That's one of the fundamental problems is that supply and demand does not work in today's healthcare delivery system. And the inefficient provider can stay in forever today because no one's holding them accountable. So all of these components are working at one way or another. Oftentimes they're working toward that issue that ultimately those people will go away. We've got to stop giving them, we've got to stop paying them for the defects because you pay the same thing for a surgery that didn't work as the one that did.
So again, this goes back to the conversation we had over lunch with the lawyer who represents all these doctors. The loser in your case, in this case, is the specialist, is the hospital systems who really have all the money. They have all the money today. And all of these models are shifting more compensation. Costs more for that guy. We've got to pay primary care more for them to do more and to spend time with our people. But again, the way your economics are built today will make a difference in whether it's actionable tomorrow. You're kind of close. You sound like you're a little farther away from getting toward a self-insured model where you reap all these benefits. So let's move on.
As we move on, we're going to be moving away from somebody else solving the problem and moving more to what you can do to help solve the problem. This last one in this segment is what we refer to as a coordinated advocacy model. There's really multiple levels of advocacy. You've probably heard the term used a lot. The simplest model is, a much more engaged customer service sort of model that's more focused on helping people use the plan and solve their problems and get their claims paid. Moving over to a clinical area is more like a 24/7 nurse line thing where it's clinical. They're giving you some advice on what to do from a medical standpoint. Then you move to the third level, and oftentimes organizations that are in this space sell these as buy-up options. It's like some of them offer all of these things in their continuum product. But the consumer purchasing one goes to the next level to help people really figure out what I just mentioned that doctor was going to do, is to find the more efficient provider, the less costly, the more higher qualified. There are models out there that you can get into with consumer purchasing that help you understand that. And then the fourth model that we're going to talk a little bit about is this coordinated advocacy, where, go ahead and flip, you're really switching over sort of how this all works, and we'll get to it in a minute. But why are these things sort of necessary? This is sort of a snapshot of how this kind of looks at today's employer segment. In the center, you got the employer who makes the benefit purchase. They design the plan. They're either self-funded or fully insured, whatever the benefits are. They force that into the employee population through open enrollment and new hire processes. And then you say, basically, you give a 40-page or 10-page or however many page booklet that's got your directory and how your plan works, and you give it to the employee and say, have a nice life, go have some health care. And then they go out and they look at all of these places where they can access different parts of the system. They're not educated to know how to do this, but nonetheless, our system today, that's how it works. And that's part of the reason why there's so much dysfunction in it. The only slide on that slide that he was just on that really doesn't affect the employee is if you're self-funded and you've got stop loss. All of those others are customer interfaces that someone could have to deal with using care. Where does that take us? we all know this, employees are really confused about how all this stuff works. Half of them are being reported that when they come out of the doctor's office, they don't remember what the doctor said. Half of the tests that they're being given are being delivered and recommended without any thought about what it costs. In 60% of the cases, people are receiving the care in the wrong settings. That's where the waste is. So how do you get at it? This system sort of adds to what was there, this health advocate in the middle. They take over all the customer service in this model. They become the advocate for your employee population, the dependents, of how they access the system, and they guide them through it. They take over the utilization management, they take over the care management, they take over the wellness components on a direct basis. They're tied in with the claim payment, whoever your TPA is or carrier, so they know what's going on. But they take over all that customer service and help people. The only thing you need to do from your plan design to make this work, and a lot of you probably already have it, is a differential copay between primary care and specialty care. You don't need to change anything else. Don't need to, if you're self-funded, you don't need to change sort of the way your product works to make all of this be delivered. Next one. That model changes utilization patterns. That's what the key is. That's the how does this really work for this particular model. Well, your primary care spend will go up because that's what they're really focused on, is having people go to that primary care doctor. They facilitate the referral process. It's not mandatory, but they facilitate it. They try to guide people. They know what's going on from a wellness standpoint, so they know what the patient what the patient is actually dealing with in terms of a condition. They drive up higher preventive care services, but all the rest of them are negatives. Those first two really are low-ticket dollar items. The big items are down here at the bottom, and these are the results that they get. Now, in this kind of company's model that does this, been doing it for a number of years, had a lot of success with it. Oftentimes, over half of their groups that they bring on board have an actual reduction in cost the first year. Some of them don't, but typically it's either a reduction or flat first year, and then a completely different slope on increases in terms of utilization consumption going forward. So this heavily is vested on intervening, changing consumption, driving down utilization, and improving the wellness of the employees.
Are these results based upon a corporation or based upon an insurance company?
They're not really an insurance company. The company that sort of built this model is an interface between the network and the insurance mechanism, if there is one. And they're basically doing
a new party into the
equation. When you look at it on paper, you're adding some administrative expense to get to this coordination and the advocacy delivery. And if it works, it's going to work on changing consumption in the future and reducing unnecessary utilization.
And how do you drive the users to use it?
They don't have a choice.
You have an ID card with a phone number on it.
Every intervention, and this company is called Quantum Health, and they've been doing business in Wisconsin. They probably have 24 customers
At least
throughout the state. They're larger, self-insured employers, but essentially, instead of having the United Healthcare phone number on there, all they have is Quantum's number. So even if they have a claim problem, they help people with that question. So it strips out all of the customer service and care management that maybe you don't trust United Healthcare to do right, and it puts them in the chair of seeing everything that's going on with that member. And the slide before, I'm back on it. They tend to get the data to look at, guarantee your ROI, and they have a shared savings model just like the pay-for-performance models do. So do I trust them? Do I have enough of a guarantee? Do I believe in the concept of coordinated care, the patient-centered medical home? But this is more an overlay. I don't trust the system to work it out. I don't trust the carrier to work it out. I like this company. I like the sound of this. And if I'm already in a TPA model, it's almost a real easy way. TPAs are willing to give away that customer service responsibility. The standard carriers that act as TPAs, they say, we're doing this, and they're not doing it. So they've been pushing the carriers to evolve into models like this. What's the United Healthcare advocacy model that they talk about? They opened it up last year or the year before. Anyway, that specialized unit that they were trying to compete with this model, but they're not doing. They don't connect to care management the same way. they don't connect to the wellness program the same way. They want you to rely on the web instead of one call, David Gruber, that's all, coordinated care, right? So anyway, it's another way to get at this patient-centric primary care emphasized model that
are there companies now out here that are selling healthcare advocate services, or is it
there's two that I know of. There's one that's very prevalent in Wisconsin.
Patient care?
No, patient care is that first box and second box and third box in the advocacy continuum. They got closer. They started doing clinical stuff the last year or so. You know, back to those slides that had 4 boxes. But this overall coordinated model, they're not there yet. And again, they charge pretty much for what they do. These guys are going to charge for it. And but patient care is doing 1, 2, 3.
Well, they started doing this one and this one. It's sort of how they came into the market, and just last year they added this one.
But the other one is really taking the whole ball and being accountable for things. So again,
but what they're not doing compared to the one we just talked about, the full one, is that they are not really intervening. You know, patient care model. They're not intervening with the physician before the treatment. They're intervening on sort of some steerage about what it might cost if you go to this one versus this one versus this one. But the care advocate model, they're actually on the phone with the primary care doctor helping find out what is the right physician to refer somebody to, and then they're talking with the referral physician and coordinating and doing the case management. You know, think back to this slide with Aurora. One of the things Aurora's ACO is bringing that they now own in that model is care management. That last model, they owned care management, not the insurance company or the claims payer.
Right. To move on, let's do a little test of, you know, like it or could see it being actionable, you know, the little horn thing if we're not expecting everything. Any from the back? And again, fully insured. This isn't ready, but the carriers they're being pressured to deliver this way. That's the main thing. So the more large employers do things, you see it trickle down into the carrier market. So any other buzzes back there on this kind of model? It's a gatekeeper overlay is what I call it. So in the interest of time, we've embedded a little more Q&A than we expected. So we're going to try to move through these other ideas fairly quickly. Those are really in the delivery, the broken system problem that we were focused on. A lot of different ways to attack it if you're the right kind of employer profile, but I think there's something for everyone there, quite honestly. The next 3 topics we're going to talk about are right here, and we put them in a bucket of incentive models. And if I had Andrea, who's over on Twitter over there, tweeting our meeting here, I came to her and said, I want a picture of how these things work together. But in a sense, you know, social wellness models, wellness in general, it focuses on your health, right? So incentives around wellness going into this bucket of health incentive accounts, we're talking about things like HSAs, HRAs, iterations of product that people get to accumulate money in, kind of feed that in our belief of an ideal state of building a strategy. Medical tourism, which is on the consumption side, comes from the other side. And if you read Terenas' book, he's incentivized choosing this provider over this provider based on the cost and quality of the transparency tools, the information that the carriers have been holding on to and hoping you dive into their website for. He pulled it out and he put it all over the place. So the bottom feeds the middle with incentives, the top feeds the middle, and that's, Andrew, that's the bag of money slide without the bag of money. The bag of money is in the middle. So social wellness. This is not, we're not going to talk about wellness. We all kind of get wellness to whatever level we're going to get it in terms of its impact, but it's really, this D. Eddington's model of 5 pillars and how it affects, how it needs to be part of culture. And the leftmost pillar is leadership, believing in it, helping establish the culture that moves on. How do you get it into your culture is the kind of the key thing. Back to the editing though. His latest book, or his most popular book, is called Zero Trend. And his philosophy is not get everybody to be a super athlete. It's don't get worse. Just stay where you are, don't get worse, and you won't have, again, the cancer is a trickier one, but the heart attack is not as tricky if you don't get worse. I'll take my most recent experience. I went to the dentist, very impressed that they take my blood pressure. Never had blood pressure problem before. I still have the card where they did it 3 times. It was like 150 over something not good, because I've never had the problem. I don't even understand the numbers. But anyway, 3 times. They did it at the beginning, they did it in the middle, they did it at the end. It just kept getting worse. So they said, we're not going to fill your tooth or whatever I still have to do until you go to your doctor and get your blood pressure level. Point is, I'm starting to get worse. Okay? So that was a wake-up call for me, and some of what we're doing in wellness here at HNI, or I'm doing on my own, kind of, I don't want to get worse there. And I can get progressively worse with blood pressure issue to the balloon tops. Again, this is not a lesson in that, but it's about social. And how many of your companies are highly encouraging or allowing social technologies in the workplace? Things like, I mentioned Twitter. Andrea is using it right now to talk about our event, or having similar social tools internally, or built into your wellness programs. Anyone like way ahead there? Got a half a hand.
Yeah, we're just starting.
Okay. Okay. So, getting from a business standpoint or from a wellness standpoint, or both? Right. Okay. Yourself too? Yeah. And again, I'll tell you, HNI as an employer, we're definitely in the experimentation mode from the wellness side of it, but we culturally, probably in the last, must be almost 2 years now, a year and a half, we've really transformed our internal culture around the use of social technologies. So instead of emails, we're getting the Twitter-like communication vehicle, which I'll snap at you if I can get back there. But anyway, that's what we're talking about. And this slide is basically saying people are going to social technologies today anyway. This is that, it might be a different PricewaterhouseCoopers survey, but they're saying 33%, or a third of the people, are using social tools to get their health information. So why wouldn't we strengthen our wellness connectivity by using the tools people are already using? And that's what this topic is mostly about. I can't go deep because of time, but let's see where I'm at. I just talked about the time. Ignore the technologies. Our communities, our social community is where we're influenced by. Steve and Gina, are my circle, and Gina just has been working and kind of dropping pounds or quit smoking or something. I'm influenced by that. That's what this concept of using social tools allows for the community to be as broad or as narrow as you want, and to truly be leveraged. How many of you have a smartphone? Almost everybody has a smartphone. And the delivery system through smartphone is just ramping up the pace that you can connect your wellness messaging through. These points are fairly self-explanatory. This last one is kind of an interesting byproduct, I guess, of using these tools. It's built on a transparent culture of communication. You can see what is working that people are connecting to and feed that content through either your own input or applying other resources that aren't in the social technologies to reinforce what people already want to hear about. So you get the term here is eavesdrop on the conversation. Have you done that in wellness? I mean, are you seeing what people are talking about and benefiting from it in terms of kind of building the rest of your communication strategy?
Yeah, definitely, especially when the big events that we're doing.
Right. again, people are out there, so use it. And again, I don't know that I have time to go into it, but this is Yammer. This is our communication kind of Facebook-like. And last night when Steve and I were doing a rehearsal, you can't see it, I'm not going to launch it, but on the right there's these kids running up and down here. The cleaning people are here and there's kids running, so I'm thinking of cleaning people's kids. And the next picture, the one on the left, is Steve practicing his presentation. And the kid said, well, no, my mom is teaching Zumba in the other room. So I go over in the other room, and that third picture is the Zumba group. And I kind of did it for effect here, but I'm asking our CFO, look, there's a huge crowd in that room. We don't have the facilities maybe to meet everybody's needs, but we could break down one of these offices and extend our wellness facilities. The point is, open conversation about what we want, what we need, is really easy using these kinds of tools. Everybody sees them. Sherry Weaver, who's not in the room, looks like a blast. Zumba's tons of fun and very innovative. And Andrea from over there looks like the kids are getting a workout. They were scaring me. They're running up and down these stairs. But anyway, the point is, open up your culture, use the tools that are working in everyday life for people, and move forward. Back to the show. So this is a wellness group we have here. The guy doing the push-ups is myself. These are two of our benefits account executives. But we're in a program called Healthy Wage. Anyone participate in that or hear of that? Healthy Wage is a wide open network around, it's really a weight loss competition that employers don't have to fund. They can if they want to. It uses social technologies. I don't know that I'm going to be able to get to it, but this Twitter, they tweeted us. They asked us, how's it going? And we said, 4 weeks in, we've lost 4% of our body weight collectively, so we're a team. We're competing against 40 teams from not anywhere around the country. And the social aspect of teamwork and collaboration and a game and a contest, that's really where the world of communication and wellness can pick up. So we're doing okay. By the way, we win. We each put in $20 over 3 months, and we have a chance to win $1,000. So the team that loses the most gets to win. It's capped at a certain healthy weight loss for the team. So people cutting 20, 30% of their weight loss don't have an advantage over someone team that cut 15% during the 3-month period. But it's the kinds of things you can do internally, you can do it externally, and it's there for the taking. Other programs, Shape Up the Nation. Tangerine is a weight loss one. This is more of a comprehensive physical activity. You see how it looks and feels. This is part of a product that we'll get to real briefly, the Get More product. This is their Get Movin' product, which is about getting people moving in a social environment with electronic pedometers that wirelessly transmit. Anyway, social is kind of where you need to go. And so I'm going to move now to the incentive accounts in the interest of time. I want to make sure we close this. This picture, some of you may have seen before, but now I'm on that middle, that bag of money in the middle conversation, that incentive accounts. Well, both on social. I got it here. Social, not every company is ready for that stuff. We got a thumbs up. How about let's use that from the back. But anyway, again, I'll tell you, when our company went to this open culture social transformation model, in a leadership team meeting, I said, we're just going to create chaos. Nobody's ready for this. But you have to take a leap. And now all of our internal conversations, not only about wellness, happen via YAM. When we're dealing with clients, that's where email has to be. But it shows up on my smartphone, it pops up. I see what's going on. I can ignore it if it doesn't matter to me. I can act on it. I can contribute where Steve might be working on something. He doesn't know that I know the answer to something. I can give him the answer, and he saves an awful lot of time and think about how that can help people with their health. So, one good vote in the back. Any thumbs downs, like we're never going there?
We're manufacturing. We don't allow cell phones on the floor ever. We discourage them highly, so it would be contrary to our culture.
To do any wellness promotion?
Even after hours.
Well, during the work,
But then we're saying, oh,
right.
it's work and we're not paying you, and then it's,
Right. Then they're more busy or looking at their phones than paying attention to what they should be doing on the job.
Yeah. Again, in the workplace may be appropriate.
Right.
Check your phone at the door. But guess what? When you're trying to promote wellness, they're dealing with that at home.
To use.
And they are using their cell phones,
they
right?
don't want emails from us when they're not working. That's our particular environment.
Right. Anyway, not uncommon. And again, taking that conversation beyond the barriers, it's a trick. But I'll consider that a wellness horns that we don't have. The whoopee cushion. Right there, whoopee cushion. Get that, Andrea. All right. Incentive models. This is really, I'm going to be very brief on this. This is how healthcare looks today. You get sick, you get care for the most part. You have to pay for it, you get payroll, you get benefits. The problem is most people don't have a lot of health care. So back to that benefit value conversation, all I get is a payroll deduction for that 70 to 80% that use hardly anything. So if we can use these incentive account models to give the healthy some reward consistently for being there, and it can accumulate the bag of money I wanted in there, it's a powerful play. And so what we have boiled this down to is how the best plans work. And they work with that top line being maintain low-cost access to high-value care. So preventive primary care. HSAs don't necessarily have this, okay? But HSAs can be built to work in this model. But there's other iterations that work this way. But keep the value in the plan that will help people stay healthy. Allow accumulation. Let it go. Oh, well, they can't take it with them. Well, why would they accumulate it? Why don't they just use it? That's the second point. Tile lifestyle. That's the main theme here. Detach it from the insurance. Give it its own identity. This is a benefit. You can grow your pot of money, connect it maybe to the wellness plan versus a reimbursement of my deductible. These other things are pretty much part of everything else that we're talking about today. So this is one client and how they gave dollars. This particular product is Get More, but there's other ways. You can do this with any incentive account. And they used their health risk assessment process and chose to give people money based on their health status. Improve your health status, you get more money. Pretty straightforward. Same kind of thing for getting some of the care you need beyond the health risk assessment. So the Get More model, when you go in the door, this guy's all happy and smiling. He's blowing one of these horns right here. He's not sick. If he goes left and he's healthy, he gets rewarded for maintaining his health. He gets to invest in health and wellness. He gets anything the tax code allows him to invest in his health. If he's got a high blood pressure situation and his doctor says you need to get some workout in, he can get approved gym membership or his treadmill. It's all managed. If he has some issues, he pays his bills. And if he doesn't, he accumulates for a rainy day. So that's the incentive model. This is the piece to take home in the interest of time. Just came out. Aetna Health Plans been doing Aetna Health Fund, not in our market, Aetna, but a leader in how consumer accounts work. Just completed the study, 7% less care and cost, comparable population mix, but this is a proof statement. Again, this will be part of our web connection after this. If you want to study it, look at it, see its applicability. Medical tourism. This is the bottom part of the puzzle. This is, I don't know where I have it anymore in my notes because I'm trying to move this a little faster. If I can move. How many folks, incentive accounts, how many of you have HRAs, HSAs? So you believe in them in some way. Are they helping control costs?
Yes, we have seen our
we won't let you weigh in.
think it's early times for us yet.
They're early on it.
Mm-hmm. We think early, but this year we did tie it to a health risk assessment completion to gaining access to that.
You get your money in, you do something, right? Changing the back end. It's really about changing the back end performance that we believe the best models achieve.
Yeah.
The first year is easy.
I don't think ours is doing all it could yet.
Okay, so we'll kind of do a sideways. There's a lot of people who thought it was really a great idea, not sold on it being the big horn blow. Okay, medical tourism is that bottom of that bag of money picture that wasn't there. It's trying to get people to really make consumption decisions based on price and quality when they need care. What's caused the need for it is this lack of transparency. How do you know what something costs? How can you act like a market if you don't know what something costs? So that's largely why medical tourism has started to grow. Okay? There's a win for the plan sponsors done right. Steve, I don't know if you know the pages that...
Page 70.
Page 70. When you get your book, page 70 is how Serigraph, again, it's just an example, deployed medical tourism not only on the everyday stuff, but they gradually got to the complex stuff, which the complex stuff that's already past your out-of-pocket limit, your calendar year stuff that I would take away in a minute from every plan. I would have a 70% plan with no calendar year accumulations and let my bucket of money build if I behave right. That's another topic. They're addressing both the high-end services, the cancer care, and the everyday stuff. And you start small with anything and you build up. They've got a more complete journey than a lot of people in this space. So, everyone, you can't read all this, but this is international tourism. And I remember reading, John Torinas used to write for the Journal Sentinel, a commentary. So he was talking about this years ago. And I'll just pick a country. Mexico costs 25 to 35% less. Why wouldn't you incentivize people to get the same type of care? I'm sure there's American-trained physicians there for 25 to 35% less. Give people the 5% bonus. That's kind of the concept that this is built on. Where's a good one? Anyway, all these countries, a lot lower cost to do it, but not really culturally aligned with what we're ready for. So we're not talking about that today. We're talking about domestic medical tourism. And what domestic medical tourism is I'll just be driving from here east to Milwaukee. If I turn right and go to Chicago, a procedure might cost $1,200. And if I turn left and go to Sheboygan, it might cost $400. If the care is the same, why wouldn't I incentivize people to drive that distance when it's planned, when it's thought out, when it's coordinated by somebody? Very powerful. This actually is just a small geography, right, Steve?
Yeah, it's southeast Wisconsin.
So this is, now instead of turning left and driving an hour that way or that way, this is drive 10 minutes that way or 10 minutes that way. It's there for the taking. And again, because we're pushed for time, check that out in the book or check your boxes in here that you want to hear more about that, and we'll do a full scope discussion on this conversation. But the information is there. It's really how you bring it out. This is Anthem's care comparison, same kind of thing. 8,000 in one place, 15,000 in another. And you'll see the Wheaton system at the top sometimes, lowest cost, and you'll see them at the bottom. You see they're figuring out how to make their margins through profit centers. Our job is to get our profit center working and help people help our profit center. Donna, the former...
right, before any provider discount?
No, this is actually, all of these tools that have been brought forward from the carriers are all now using episodes of care. So it's not a single CPT code. It is, if it's an MRI, it pays for both components, the reading of the film and actually taking the film. In the last one, I think we were talking about a knee surgery, so it's the pre-op, post-op care for having your knee repaired. And it's when you use the carrier's websites, whoever carrier you may be using, it's giving you the discounted cost. Now, you'll see there's a range here for each one of these things because you can't guarantee what the cost is really going to be when you walk in the door because they don't know how long they're going to knock you out.